Good morning, everyone. I'm Dr. Clifford Deal, President of Medical Society of Virginia. Thank you all for joining our latest webinar. Before we start, I'd like to remind everyone that the MSV and its staff have continued to work very hard to update our website with important resources related to COVID-19, and that's at our website, msv.org/COVID-19. We could let everybody know all of our webinars are recorded and are posted to the website that is msv.org. Secondly, this is the official CME statement that I have to read. This webinar has been planned and implemented by the Medical Society of Virginia and VCU Health and is eligible for CME. So I'd like to mention the following for CME purposes. No commercial support was received for this activity. No reported conflicts of interest for any individual in a position to control the content of the program or speakers representing the program. We are recording attendance and will submit to VCU for CME credit following the webinar. VCU will issue a certificate to you at the email that you registered with. Lastly, before we begin, please remember to use the chat function to ask questions while our speakers are presenting. I'll try to moderate those after they're speaking. We'll ask you to try to keep your questions focused on Dr. Peake's data and presentation and on the telemedicine reimbursement with Dr. Elward. If we don't get your question at the end of the call or have a question on another topic, please email governmentaffairs@msv.org. Joining us today is Dr. Lilian Peake, the Virginia Department of Health State Epidemiologist, and here to discuss updated data for COVID-19. After Dr. Peake, we will hear from Dr. Kurt Elward, former Medical Society President, practicing family physician, and Senior Medical Advisor to the Department of DMAS, with some recommendations regarding telemedicine reimbursement. First on the agenda, we have Dr. Peake. Dr. Peake, good morning.
Good morning, everyone. How are you? Can you hear me okay?
Great. Read you 5 by 5.
All right. Well, thank you for inviting me to join you this morning. I'm going to cover 4 topics: an update on the epidemiology of COVID-19, testing, what we're looking at around modeling, and then some guidance around personal protective equipment and healthcare workers potentially exposed to COVID-19 and healthcare settings. So first, for the epidemiology, this is an epidemic curve of confirmed COVID-19 cases across the globe, and this is by date that the case was reported, and it shows it by the World Health Organization region. And so you can see the shift over time. Initially, you see the epidemic curve in China, and then as the cases decline in China, you see that it significantly begins to increase in Europe, and then some proportion in the Eastern Mediterranean and the Americas. There's also a small proportion of cases in Africa and still some in the Western Pacific. So since the last time I provided an update, a lot has changed. And I thought it'd be helpful just to look at what the numbers were in the beginning of March and where they were as of April 17th. So as of March, there were 88,000 cases in the world, and we're now up to over 2 million. Most of the cases at that point were in China, and the US is just starting to see cases. There were also cases starting in other parts of the world. Now, as of April 17th, you can see that the United States has 632,000 cases as of April 17th, a lot more than that now, and almost double that are in other parts of the world. You can also see the deaths here, and so you can see the deaths in China compared to the United States and other parts of the world. So just as you saw in the epidemic curve, what we thought was overwhelming in China has really been overshadowed by what's happening across the world now. This is an epidemic curve of the COVID-19 cases in the United States, and this is by the date reported. And so as of the 22nd, there were 828,441 cases in the United States and 46,379 deaths. You can see that the curve, when you look at the United States as a whole, isn't sharply increasing, but If you look at the cases by state, you can see that there are very different experiences going on across the country. And so we see some states with significantly more cases than others. And an interesting article was presented in the MMWR early in April, where they looked at the cases and deaths and incidents in the United States from February 12th through April 7th. And at that point, they showed a case doubling time of 6.5 days. And 2/3 of all of the cases were in just 8 jurisdictions: New York City, New York, New Jersey, and then some other states. And then of those key areas, 53% of the deaths had occurred in New York City, New York, and New Jersey. So you can see that some areas in the country are having much more impact from COVID-19. If you look at the national cumulative incidence, it's 120 per 100,000, but that ranges significantly across states from 21 to 950 cases per 100,000. So some of the factors that have been attributed to the geographic variations include the timing of the introduction of the virus into different communities, the population density where the outbreaks are occurring, access to testing, when and how community mitigation strategies have been used, also the ages of the infected populations, especially when there is an outbreak, and I'll show you a little bit about that or how it's affecting Virginia. And then the underlying diseases of infected populations, especially when there's an outbreak. And then, of course, the social supports of infected populations. So this is a snapshot of COVID-19 cases in Virginia. As of April 23rd, there are 64,518 people had been tested as far as reports received at the Virginia Department of Health, and we had 10,998 cases. We are now looking at both confirmed and probable cases. So probable cases don't require a confirmed PCR test. And then these are hospitalizations that were identified when the case investigation was completed by VDH. So this is an underrepresentation of hospitalizations in Virginia, and we're working on trying to identify data, better data about hospitalizations through the Virginia Health Information. But right now, that is what we have. There is also hospitalization data available from VHHA on their website, but that's looking at census data. So we don't have perfect hospitalization data right now. Very few states do, but both sets of data, what we're looking at from VDH and VHHA, can tell us, can provide good information. So one advantage that we have of looking at the hospitalization data from VDH is that this is from the case reports, so we're able to look at the hospitalization data by age and other demographic factors. There's also been 372 deaths that we've identified, and again, this is probably an underrepresentation. We've now started a process of reviewing vital records to identify deaths that may not have been reported to us. This is just looking at cases in Virginia by rate so that you can see, I'll just go back for a minute, you can see that's by number on the map, which you would expect would follow the population density. This is by rate, and so you can see it doesn't always follow population density. And on our website, every day we update the numbers, and you can look at the cases by number or rate. So I encourage you to look at our website. This is the epidemic curve for Virginia, and the way that we create this curve is that we're trying to look at the case by date of illness onset or symptom onset, but that's not always reported when we receive our case reports. So we have a methodology to get as close to that date as possible. So we are trying to look at a true epidemic curve based on date of onset, but it's not perfect. And I've put here when the first executive order putting more social distancing measures in place in Virginia occurred and when the second one occurred. Here we're still waiting for cases to come in. So typically it takes a little while, so it doesn't necessarily mean that it's decreasing. We're just still waiting for the cases to catch up. And also you can see some days where there are a smaller number of cases, and that has more to do with the way the data are entered into our system. So I also wanted to show COVID-19 data by the demographics that we collect. So this slide shows you the data by age group, and this is as of April 21st when there were 9,630 total cases. And so what I'm showing you is the percent of the population of Virginia by age group. So there are 12% of Virginia's population is age 0 to 9, and 13% is age 10 to 19. And then I'm showing you a comparison of the percent of total cases, total hospitalizations, and total deaths of that age group. So you can see among children and young adults that while they take up a good portion of the population, there's a very small percent who are confirmed cases, and we haven't had, and a very small percent with hospitalizations and deaths. So these numbers are rounded out. So that's why you're seeing 0%. But, so then if you compare that to the age group of 70 to 79 and 80 and over, you can see it's a smaller proportion of our population, but a much larger proportion of deaths. So this does show you just the increasing risk of death with age. And this is a breakdown of the cases by race and ethnicity. And honestly, for this slide, it's really a plea to you to ask when you are requesting a lab on your patient and you fill out the lab report, if you could please indicate the race and ethnicity, because unfortunately, most of the case reports that we receive are through electronic lab reports or from the labs. And that's where we're getting a lot of the demographic data. So you can see that it wasn't reported for 3,072 cases, so it makes it really hard to interpret the data. So we also have a system where we track the COVID-19 outbreaks that are reported in Virginia, and this is as of April 21st. Because COVID-19 is a new condition and we it's not endemic yet, or it's becoming endemic, we actually count 2 or more cases as an outbreak, and we're tracking them by type of facility just to understand more where the risks are. And so we have a broad category of congregate setting, and that could be a variety of things. Thus far, it's been outbreaks in adult daycare, apartment complexes, churches, event venues, gyms and spas, neighborhoods, private homes, and a shelter. And an important takeaway from this slide is just the proportion of outbreaks that are occurring in long-term care facilities. So that's the green. But there have been some interesting articles that have come out in MMWRs and some other journals to help us understand the epidemiology. And this article did talk about risk factors for COVID-19 outbreaks in long-term care facilities. And what they found was challenges to adhering to infection control practices. A lot of the long-term care facilities had inadequate PPE and other supplies. Also inadequate staffing. They had found that staff were working while symptomatic with COVID-19. They also found that some staff were unfamiliar with PPE guidelines, They found that there was delayed case recognition, and that was attributed to a low index of suspicion for COVID-19, the difficulty of the clinical diagnosis, limited access to testing, and then there also what they found inter and intra-facility transfer of residents contributed to the outbreaks. We're finding the same, anecdotally, we're finding the same in Virginia. So I do think it's interesting just to look at the COVID-19 symptoms. We are seeing now other symptoms that when I presented to you last, we weren't aware of. And so we have broadened our, when we're looking at COVID-19 symptoms, we really are looking at a more broad range of possible symptoms. There's also been a lot of information that's come out about asymptomatic and or pre-symptomatic spread of SARS-CoV-2 virus, and this is still being studied. There's a number of different studies, and what we have found is that there could be 2 to 3 days of pre-symptomatic spread in some patients. Also, there are some studies that have shown some children and some elderly people are asymptomatic during their entire infection course. And we are definitely seeing infected but asymptomatic people in long-term care facilities. That's been shown in studies as well as in Virginia. There's also some data that shows prolonged PCR positivity in some patients after symptoms resolve. And it's not clear how that relates to the infectiousness of the patient, and there's studies that are ongoing to try to just understand that better. So this was an MMWR article that came out on April 17th, and it looked at healthcare personnel with COVID-19. Most of the cases between February 12th and April 9th did not actually have this data, so they were looking at a very small subset of the cases. So among 9,282 healthcare personnel identified at that point, 92% had cough, fever, and or shortness of breath. 73% were female. The mean age was 42. 38% had at least one underlying illness. 55% reported contact with COVID-19 only in a healthcare setting. About 8 to 10% were hospitalized, and then 2.5% were admitted to the ICU. 0.3 to 0.6% died. But we are in this, among these patients as well, we saw more affected who were older. So 6% were aged over 65, were aged 65 years or older, and they also accounted for 37% of the total deaths. So I wanted to take a minute to go through testing in Virginia. So we're trying to pull all of our testing data together to understand more about what's happening in Virginia with testing. And so what this slide shows is tests that have been reported to VDH. So we do require by regulation that all tests are reported to VDH, and we want negative and positive tests. And we are getting a lot of data in. It's probably not complete. There are a lot of smaller labs that have come on board, and they're probably still in the process of trying to report tests to us, but we are trying to track that. And we've seen steady gains in testing by number of day, the number of tests per day reported to us in March. And then in April, it really started to plateau at about 2,200 tests per day. So what this is showing you is the number of tests per day that are reported to us, and then this is the cumulative each day. And then we're also trying to look at the test by percent positive tests. So you may have seen some of the news about the World Health Organization putting a goal out for the world to have at least 10% or lower, I would say 10% or lower test positivity rate. And so we're starting to try to understand this in Virginia. So we get the question a lot, how much testing should be done? And this is one metric that you can use to look at that. And so what this shows you is the tests per day that are occurring in Virginia are orange, the orange line, and then the percent positive tests by day is the red line. So like, for example, on this day, there were only like 2 tests, and so we had a high positivity rate. But the test positivity rate has been increasing, and now it is about 20%. So it does tell us that we should be doing more testing in Virginia, which isn't a surprise to any of us. So this slide I just received last night, and I thought I would share it because we are trying to understand this. So the Virginia Department of Emergency Management it has a data team together, and they are trying to track different metrics through this pandemic. And one thing they're trying to understand now is our testing capacity and whether or not we're fully taking advantage of that in Virginia. And so what they have put together for this graph is what the capacity of testing is in Virginia. And then they're comparing that to the actual tests that have been completed. And they're also looking at the pending tests. And so we can see that there is capacity for testing in Virginia that's not being fully utilized. And that is something that we have heard from smaller labs and from hospital labs. And we went through a very brief time where we also had more capacity at the state lab. So, and I'll talk about that in a minute as well. So up until very recently, only molecular tests have been available for SARS-CoV-2 testing. The FDA has granted emergency use authorization for nearly 40 molecular tests so far. So three have been specifically approved as a point of care test. That's the Abbott Diagnostics ID Now, the CPID Expert Express, and the NISA Biotech's Acula test. And then on Tuesday this week, FDA approved the first molecular test for at-home specimen collection, and that's a LabCorp test. In April, serologic tests have been entering the market, and we anticipate more coming in the next weeks and months. I'll share these slides afterwards, and there is a link here that you can get to FDA list of tests that were granted an EUA. So although there are a lot of serology tests that are coming out for diagnostic research and surveillance purposes, there are still a lot of problems with these tests. So first of all, the immune response to COVID-19 is not well understood. We do not yet have CDC guidance on how the results of serology tests should be interpreted, so we still aren't sure, what a positive result would mean, whether there's cross-reactivity with some of the more common coronaviruses. We also don't know how long the antibodies might persist after infection, or what levels are considered protective against future infections. So these are this is all under study now. There's a group with CDC and NIH and others that's really trying to understand how to use serology. So at this point, it's more recommended. It's being used in some studies by CDC in different areas, geographic areas around the country, and really trying to understand how to interpret it. So right now, we're at a population level to understand surveillance, and for research it's acceptable, but it's not quite there yet for diagnostic purposes. So as of Wednesday, FDA has granted an EUA for 4 serology tests for diagnostic use, and 2 are rapid diagnostic tests, and the other 2 are an ELISA or modified ELISA. So for point of care testing, so to improve the availability of testing, FDA has issued an emergency use authorization for CLIA-waived point of care diagnostic tests, and the authorized setting for each test can be found on the FDA's website. So as of April 22nd, there are 3 CLIA-waived point-of-care tests, and they're all molecular tests: the Abbott ID Now, the CFIAT Expert Express, and the MESA Biotech Accurate, as I said. It is important to know that the sensitivity and specificity of these tests does vary. So looking at testing availability. So for testing at the state lab, DCLS, because we did have some increase in capacity that wasn't being fully utilized, we revised our criteria for public health testing. So if you do want to request testing through DCLS, VDH approval is needed. We're reviewing the request to make sure that they do meet one of the criteria and to ensure that we actually have capacity at the state lab. So right now, DCLS can test about 450 specimens per day. That's statewide. And we are working now with UVA, VCU, and Virginia Tech to extend public health capacity. They're going to help do some testing for point prevalence surveys, and so that will help so that the DCLS testing can really be focused on these other test criteria. So if you want to request testing from DCLS, there is an online form, and so and you can access that from our website, from the guidance page, and that's how you would request the test. So for private labs, we're also maintaining a list of private labs that are conducting testing in Virginia, and there is no VDH approval necessary to order COVID testing from a private lab. And to try to increase testing, there's more community testing that is being planned and implemented now. And again, VDH approval is not necessary for any of that testing. So the criteria for DCLS testing, we are still looking for testing symptomatic persons. The only exception to that is if there is a point prevalence survey in a long-term care facility or another facility where you're working with a local health department. So the other criteria are we're prioritizing testing for healthcare workers and first responders, for patients who are hospitalized, for anybody who resides or works or is about to be admitted into a congregate setting. We're also, of course, using public health testing to investigate clusters, so outbreaks. We've also now increased the availability to testing for people who have an underlying condition that increases their risk of severe disease. And we have that listed on our website. We also have testing available for people who are uninsured or underinsured and aren't able to access the testing anywhere else. And then also testing for newborns of mothers with COVID-19 who are diagnosed at delivery. And that can just help with some of the questions about infection control for the mom and the baby. So I've listed here, just included a slide that makes it easy to access testing resources in case there are questions. With all of these new tests, there's lots of questions, and the FDA is keeping up with FAQs. So I also wanted to spend a few minutes talking about models. So at the Virginia Department of Health and with the Virginia Department of Emergency Management, we're working with 2 groups. First is the RAND Corporation, and we've asked them to help us keep track of the different models and understand how they differ, and to help us interpret the models that are coming out about Virginia. And so these are some slides from RAND, and there are 2 different types of models that you can get access to. One type of model is a statistical model, and so the IHME model that you've probably seen and heard a lot about is a statistical model. And then there's also systems dynamics models, And the UVA model and the CHIME model are both systems dynamics models, and they both perform very differently. So there are strengths and weaknesses to the different types of models. So if you look at a systems dynamics model, it is good at looking at the rate of spread. And if you look at on the other hand, if you look at the IHME model, it is not suitable to look at the extent of spread. But besides that, they are somewhat suitable to look at both of them, the degree of a threat, timing of the peak, and severity. And it's important to realize that models are built on assumptions. They're not, and those assumptions could be wrong. The reason that we use models is because we're trying to understand what could happen in the future. And so they're not you can't use them instead of surveillance. They're more a way for planning for how to prepare for the future. So we have been working with UVA. They have created a Virginia-specific model. And this is, as I said, a systems dynamics model. And what that means is that they're simulating the virus spreading through the state. And they look at the proportion of the population that is susceptible and then over time becomes exposed, and then the period of time where the patients are infectious, and then once they've recovered and they're no longer infectious. And so they're looking at how the virus can spread with different proportions in each of those categories over time. They also look at the data at the county level, and then it's a meta-population model, so all of that information then comes up to inform the model for the state. And they have a number of different mitigation factors and disease dynamics that they put in this model, and they run all of this information on high-performance computers, so it's really crunching a lot of numbers. We then provide them our confirmed case data and all of our key aggregate data so that they can compare what's actually happening with their models. So this just shows the short-term projections, and the solid line, the solid black line, is what's actually happening. So they've put together projections for a number of different scenarios. So the first is this line shows if there are no mitigating factors. So this is what is projected based on the initial data and their model for what would have happened if there were no social distancing measures. The next ones are impacts of potential social distancing measures. So they have two scenarios for slowing the spread. So that's assumed that the social distancing that's put into place would slow the rate of growth, and that's these two lines. So you can see the effects of those mitigations. And then there's another set of assumptions where they have more extensive social distancing measures. There's more of an effect, and that's called pausing the rate of growth, and so that's these lines. And so you can see here that where we're tracking in Virginia right now is as if we're pausing the growth. And they're also using short-term projections to look at how the number of hospitalizations and the rate of growth, and then also ventilated cases. So they're also looking at long-term projections, but we really have to be careful. You know, they have said many times that you can't take their long-term projections and say this is when the peak is going to occur in Virginia. Again, it's more of a way to model what could happen so that we can prepare for that. And what they're showing is this is the long-term projection for the peak if there were unmitigated growth, so we really didn't have any interventions, and this is just how the virus worked its way through our population. And then these are the different effects of actually having mitigation, community mitigation strategies in place. So you can see that it pushes the curve to the right. And then this is how we're actually tracking with the daily change. They're also modeling hospital demand and capacity. And, you know, capacity is very hard to estimate in the future, but they're looking at 20% of hospital beds that could be used for pandemic under normal conditions. And they assume that a hospital under emergency conditions can expand to 120% capacity. And this gives 40% of a hospital's beds as an estimate of how many COVID patients they can absorb. So what they're finding is that the social distancing postpones the time when capacity is exceeded 1 to 2.5 months. So some key takeaways from their model are that projecting future cases precisely is impossible, but you don't necessarily have to do that. So you can look at conclusions based on comparing what's actually happening now with those models. And for what we're seeing now, the current social distancing efforts are working. And then under the current conditions, Virginia as a whole will have sufficient medical resources for the next couple of months. And it also, the projections are showing that lifting social distancing restrictions too soon could lead quickly to an increase in the cases, and we could get back to that exponential growth. And then they're saying that further modeling might help us understand the effectiveness of using containment strategies. So really ramping up our ability to do testing, isolation, contact tracing, and quarantine. The more we're able to contain, the less we have to use the community mitigation. So the modeling can help us judge that. So I also wanted to share some guidance with you on personal protective equipment. So CDC recommendations for PPE when caring for patients with confirmed or suspected COVID-19 includes the eye protection, respiratory protection, gloves, and gown. And when respiratory supplies are running low, N95 should be prioritized for healthcare workers conducting aerosol generating procedures. So as of April 13th, universal masking for everyone entering a healthcare facility was recommended to help prevent transmission from infected individuals who may or may not have symptoms of COVID-19. Face masks are recommended for healthcare personnel providing direct patient care. And then VDH also began recommending cloth face mask coverings for those going in public. Cloth face coverings are not considered PPE because their capability to protect healthcare personnel is unknown. So there is a difference, and we're trying to distinguish that. I know that's going to be challenging for the public to understand. I've put together this slide that has PPE resources for you. And I'll share that, as I said, the slides afterwards so you have access to that information. And then I also wanted to talk about exposure in a healthcare setting. So CDC recently archived their guidance for assessing and managing potentially exposed healthcare workers in healthcare settings. And they did this because there's ongoing transmission now in communities, and COVID-19 can be spread by people who don't have symptoms or who eventually develop symptoms, so among the asymptomatic and pre-symptomatic populations. And so because of these factors, the feasibility and benefits of performing formal contact tracing is limited. So CDC now recommends that the healthcare facilities forego the contact tracing for exposures in favor of universal source control for healthcare personnel. So this does mean wearing a face mask at all times while in a healthcare facility. And We are still doing case and contact investigations in public health, but the volume of investigations has become so large or so high that some districts are having to prioritize those investigations. They can't do all of them at this point. And so they are trying to prioritize investigations if the case is a healthcare personnel. But it is important for the healthcare facility to let people know if the person with COVID-19, we have to share this information. So we're calling the healthcare facility to let them know that a person with COVID-19 was at their facility if we're doing that investigation and do come up with that information. But the difference is that we're no longer tracing each and every healthcare worker that the case had contact with to assign their exposure risk and make those individual recommendations of what the workers should do. So it's important that facilities implement the universal source control and have symptoms for actively screening healthcare personnel for fever and symptoms of COVID-19 before they enter the facility. If healthcare personnel who develop symptoms are identified, they need to stop working immediately and be evaluated. And as I said, we are prioritizing testing at DCLS for healthcare personnel. So for healthcare workers with confirmed or suspected COVID-19, CDC recommends a test-based strategy to determine when they can return to work. This means excluding from work until fever is resolved, respiratory symptoms are improved, and there are 2 consecutive negative specimens collected at least 24 hours apart. If the test-based strategy is not feasible, then a time-based strategy can be used where the infected worker is excluded until 72 hours after fever has resolved, respiratory symptoms have improved, and at least 7 days have passed since symptoms first appeared. So regardless of the strategy, the healthcare worker should follow certain work restrictions when returning to work until 14 days after symptoms appeared or symptoms completely resolved, whichever is longer. And so this means wearing a face mask, avoiding contact with severely immunocompromised people, and self-monitoring for symptoms. I've also put together a slide that has CDC resources for you on healthcare exposure. And then I've put together some slides that just have some new or updated VDH resources. We're continuing to update our website as the information changes so rapidly. And then also just some new or updated CDC guidance. They continue to update their information on a regular basis as well. So I will stop there and see if you have any questions.
Dr. Peake, thank you very much. That was a tremendous presentation on so many things that physicians across the state are really interested in I hate using this word, the granular details and not just the fluffy picture. There are a bunch of questions that have come up in the chat. Some of those are broader questions, which I'll sort of start off with, is combining all models. Is there going to be a peak, do you think? Again, we know not necessarily an official VDH opinion, but Lilian Peake opinion, is there going to be a peak in the late summer, fall, and how do you think that impacts kids going back to school or college in the fall?
Well, when we begin to lift we have to at some point obviously lift the community mitigation strategies that are in place. So we have to get the economy working again. So there will be an increase. And the timing of that's going to depend on when we lift those restrictions. And so that's what we'll have to watch. We're working now in the public health side to really gear up and to increase our staffing to be able to do more of the containment strategies. Public health across the United States is trying to increase its capacity to do this. It would be, if we're able to do that at a level to actually affect that curve, it would take significantly more resources than we've had in public health for decades. So it's something that we're trying very hard to gear up for, but we'll have to see how we're able to do that. And so the peak is going to depend on how the containment can start to sort of take the place of some of those community mitigation strategies. And so it's really hard to predict that right now.
Sorry, I know that was a really tough question. Maybe this was a more specific one. One of our listeners typed in just asking about the sensitivity and specificity of the tests used by the state lab.
So they are very sensitive and specific. They're over 95%, greater than 95%. When they did the testing performance data, they exceeded what the limits of that were. So they're excellent.
And then is there a reference where our listeners could go to for some of the other lab tests that are available? As a couple of people have texted in and say, you know, we don't, there's a couple that are available, but we wanted to evaluate the effectiveness essentially of each test head to head.
Yes, and that's something that we've been trying to understand at VDH too. We just put the governor is convening now a testing task force so that we can get better information. We have been trying to collect information on the performance of tests, but it's been really challenging. The labs don't have to provide that to us. So that's something we're trying to dig into now. And we do have information about tests on our website, but it doesn't include the performance. That's something I'd like to add, but we are actively trying to understand how we can get that information. And when we do, we will share it.
That'd be great. I think a lot of people are very interested, you know, and we've become so interested in evidence-based medicine. So we are looking for the evidence. And along that line, it seems we hear so much about the antibody testing, but without data as how to interpret the tests, those are, while that seem to be a positive thing, what are we supposed to tell our patients about that?
I mean, at this point, they're not recommended for use at a patient level. There's a lot of caution around that, and we're waiting for CDC and other federal agencies that are working with CDC to come out with guidance so that we can feel comfortable using them at a patient level. But right now they are being used at a population level in some studies across the country, and so that's useful. And we're hoping that information will come out quickly on what tests might have better performance, and so that we can look at doing a seroprevalence study in Virginia at some point.
Thanks for that. So one of the questions from one of our pediatricians was just asking if their practice, of course, you know, younger kids, they all present with, you know, cough or cold symptoms, and they are masked, but and the smallest children just will not wear the masks or tolerate them. And so, and then they're finding out later that some of those folks are COVID positive. And the comment is that CDC says if they aren't wearing eyewear, then they're at medium risk, that is the providers, and then they should be home for 14 days. So does that mean that in a pediatrics office that you ought to be wearing eyewear all the time?
Well, these are really challenging. So there are some, yeah, I mean, it's just a challenging situation. So if you're able to do any triage, I know that's just really challenging with kids in a pediatric practice. If you are able to do triage so that you can at least, children who are symptomatic, you can at least focus your PPE and wear the full PPE, obviously with those settings. And then I think it's just, you know, it depends on your practice and the kids that you're seeing and the volume of COVID-19 in your area. I mean, at some point, if you have the ability to have that level of PPE, it may be something that we're looking at. There isn't clear guidance on that right now, and I don't have a great answer for that. I think I would look to your professional associations and see what AAP is recommending. It's something I can look into more and get back to you on. I don't have a great answer because it's just a really challenging situation now that we see the level of asymptomatic spread.
Okay, so one of the questions about the UDA model, and they just wanted to understand exactly what the pause represents. And my interpretation of that is that means we paused the growth of COVID?
Yes, it keeps it sort of at a plateau. So basically what they're looking at is the effect, and they're modeling what the effect would be of different levels of mitigation. And that's not tied to specific strategies, but it's more what the effect would be. So it's slowing the growth if you have a certain level of effect, like the mitigations that you put into place are working at a certain level, and the curve is still increasing, but not at the same exponential rate. And then the pause is that the curve actually flattens out a little bit. It reaches a plateau.
Perfect. So a couple questions about PPE. That was overall, that was just a tremendous slide. We're going to put on sort of a roadshow, if you will, on social media to how to link back to this. I think there are probably a couple hundred people on the call this morning that you could review all this data so that you, and especially the hyperlinks that would take you to some of the testing criteria that are on. But one of the questions about PPE, and that is, how do physicians get PPE for their office? And is that through a VDEM request?
So there are, if you're a small private provider, you can try to reach out to your local health department to get information about how to access PPE. The healthcare systems are ordering PPE. VDEM is ordering PPE. And so I think there's a number of ways to try to access that now. I have heard recently that the state has had some success in procuring PPE. So I think probably the best thing is to reach out to the your local health department to see if there's a way that they can assist you if you're not able to get it through your healthcare system or some other method. And it would be helpful for us to get feedback about struggles that you're having so that we can help, talk through that. We do have a PPE work group. We can take that information back to them. And so if you provide information back, if providers provide information back to you at MSD and you share that with us, that would be immensely helpful.
That'd be great. We have staff on the call taking notes as we're going through this. I know everybody saw the headline this morning that the governor announced yesterday we would extend the elective surgery ban until May 1st. But one of the questions that are coming off from offices are, what's the feeling on well visits in the office at this point? I know vaccination rates are way down across the state. Can you comment on that?
Yeah, I think this is, again, we do have a healthcare coordination work group, and this is probably a better question for them. They're looking at these issues and trying to understand them. So I might refer you back to Dr. Jabari. And we can try to get him to come and give an update about, really trying to understand the healthcare workforce issues and how to manage that.
So another question coming through is, are some of the ethnic disparities, is that related to testing, do you think, or is that related to other factors?
So we really just don't have enough information yet to understand that. But we are seeing some differences in testing among different groups by race and ethnicity. So it's something that we need to understand better. So we hope that we'll get more data by race, indicating race and ethnicity, so that we can do some more analysis of those cases and see if we can find any trends, or we can dive in and get more information to better understand that.
Dr. Peake, this was overall a terrific webinar. We'd like to go ahead and get on your calendar again in a couple of weeks because whatever the situation is today, I'm sure it's going to change. And I think physicians across the state are texting me and coming through the chat about that they really are interested in these details. So thank you very much. We have one more speaker for this morning. Just in the purpose of this, we're going to ask Dr. Elward to come on in a minute to just talk about telemedicine, telehealth reimbursement. a lot of things he's going to talk about are going to be on our website. Again, these are open to anyone right now. And so, Kurt, are you on the line?
Yes, I am. Thanks. Thanks.
Right.
Can I have the first slide? Great. Great. Yeah, I know it's near the hour, so I'll go through this. Next slide. Yes, there's a lot of challenges, as you all know. I think this is a lot on anybody's plate, and I just want to emphasize that your medical society is dealing with all of these in a very proactive way, and really, really appreciate the great team we have. I'm going to be talking a little bit about coding and documentation. There'll be more on the website, but I hope this will be helpful this morning. Next slide. Next slide. Good. I want to give a shout out to the Tele-Health work group led by Dr. Ruban and to Jay Andrews, who developed this slide, which looks at the various coverage for COVID testing, the differences between the two codes and what you can use, and PA requirements. This is something that the VHHA and the VDH did. You'll see in the column where it says COVID telehealth coverage for professional claims, there's a lot of yeses there, but the devil's in the details. And we've developed some detail on the site that I'll present to you in this next slide. One of the major questions is, what do I bill, and if I do my best, if I have the best sort of Maserati telehealth mechanism in the world, what are my 85-year-old patients going to have on the other end? And so sometimes we're really in the position where we can only do phone-only visits. Are those reimbursed, or do we have to code them at the lower paying codes? The good news is we went further into this data, and Anthem and Care First are the only plans that are not allowing office-based codes, that is 99214s, 99211s, nobody knows 99211, but 213s, 214s at equivalency if you do a phone visit versus a television visit, okay? And almost all are, which is really great. That, as you can see on the second column, is time limited. That will change over the summer as they anticipate more physicians and hopefully more patients can do video visits. And I know a lot of you are trying to be very creative about how to do that. I want to give a shout out to Medicaid, because they were one of the first to say, if you give care, we're not going to argue about whether it was phone or by video. You give the care, we'll cover it. The point of service does vary. I think the default should be 11, although different ones will ask you to bill a point of service of 02. Most of that is for following televisits, like what is a televisit, what isn't. Just to review, 02 is where it's originating from the patient's home. 11 is where it's originating from your office. The modifiers are different. There was a back and forth about should we do it the traditional GTs or the 95s. For the most part, either one will work. The default should probably be GT, but 95 will work. 95 is a newer code that was developed by the AMA. Medicare is not covering television visit, video visit. They're not covering video the same as phone. Phone is a lower code right now. Hopefully that will change. Be very sure that you're billing with a point of service 11, as if it were in your office. If you bill an 02, you will get much lower reimbursement. So Medicare understands this. Just make sure you're putting your point of service as 11. Next slide. Now, these pertain to outpatient office-based services, especially in primary care evaluation codes are the ones we're talking about. Inpatient codes are different, and at this time, there's the allowance for telehealth from inpatient to outpatient sites is variable, and that hopefully will catch up pretty soon. Next slide. Again, double check whether your insurer wants a 95 modifier or a G2 or a GT modifier. That may differ for plans, and unfortunately, it may differ whether it's say, an Anthem Medicaid plan versus an Anthem commercial plan. Your coders will probably be able to figure this out pretty quick, but just be careful about that. We did not include all of the possible carriers in Virginia, but MSV will have a list of several other major insurers, and the Matrix site, which is on the MSV on the MSV site, has a whole slew of other insurers based on where you practice. Next slide. Preventive care visits are still somewhat variable and in process. I can tell you that Cigna and Anthem, and I believe Aetna, are starting to cover preventive care visits by telemedicine. So that's a really good advance. I put 99421s and 441s in there. Those are very confusing codes. Medicare has traditionally not covered the 441s, whereas a lot of commercials are covering them. As of about a week ago, Medicare has changed their guidance significantly. So you'll probably be able to use those codes based on the circumstance. I think the bottom line is the default for most of us should be to try to bill the office visit codes, the regular E&M codes, and make sure that you're billing, like I said, again, the correct point of service. Cigna's an example, not pointing at them, but pointing them to them as an example. The way they have their system structured is that if you bill 02, it can be about a 20% reduction in payment compared to the point of service 11. So just be really careful. For Medicaid, if you bill point of service 02, we pay the same, doesn't make any difference. Above all, document your time. There are some really great changes in how Medicare is covering visits and the stipulations as to the how much of the physical exam you have to have, but you will always have a backup if you put in the time. So, you know, and sometimes I know that five minutes can seem like 2 hours, and 2 hours can seem like 5 minutes with some patients. So just make sure you document what you're doing. Next slide. Next slide, and we'll stop there after that. Anyway, we won't go into consultations today because I think we're running out of time, but we hope that those resources will be helpful. Thanks to Taylor and Kelsey on the staff who've been really great at putting the resources up on the site. I'd be glad to answer any questions for you.
Thanks, Kurt. That's a great comprehensive talk. We will put that on the website later on this afternoon so that we can serve as a reference. There have been, of course, a lot of questions about how we all manage this as we going through telehealth. And so thank you very much. So we're at the hour, and we're gonna stop there. Thank you all. Unfortunately, I don't have time for a lot of questions. Please email the MSV Government Affairs Office if you have questions that we didn't get to. But thank you very much. Wash your hands, be safe. It's been a privilege to serve as your president during this time. We'll see you probably next week.